Dr. Lindsay Allen is a health economist and policy researcher at Northwestern University's Feinberg School of Medicine. She evaluates the effects of state policies on healthcare access, quality, and outcomes with a focus on marginalized populations. Her work, funded by the National Institutes of Health, CDC, and the Agency for Healthcare Research and Quality, has been published in JAMA, Health Affairs, and other peer-reviewed outlets. I'll turn it over to Lindsay.
Thanks so much, Kate. I am so happy to be here today. And thank you so much to the organizers for having us all and bringing us all together, and especially to everyone I've been working with over the past week to make sure that this show runs smoothly and flawlessly. It's been a ton of work and it's much appreciated. So today I'm going to talk to you guys about the naloxone care cascade. And so we're going to share results from a national study, which you guys have heard a lot about, thanks to Dr. Burkett, called the NMURX. I won't have to go into too much detail to explain it, but we're going to talk about how seemingly small drop-offs in this care cascade can produce really large disparities in who survives an overdose. So by way of motivation, we are looking right now at rates of opioid overdose since 2018 through 2023. And so one of the main takeaways here is that we see that although historically opioid overdose deaths have been highest among white individuals, we've seen that curve bending over the past couple of years. And so while the white communities are experiencing a decline in overdose deaths between 2022 and forward, we're actually seeing increases in overdose rates among individuals belonging to racial and ethnic minority groups. So you can see in the upper right-hand corner, among Black individuals, we see that the opioid overdose rate has more than doubled since as recently as 2018. We now see the rate is almost 38 per 100,000. And so it doesn't look like it's tapering off anytime soon. And we see increases also among Hispanic individuals and Asian individuals. So one of the best tools that we have to immediately reverse overdoses is naloxone or Narcan. You can see the brand name and the picture on the right there. So Narcan is a community administered medication. And so you can take the nasal spray, and I, as a lay person, can carry that nasal spray along with me throughout the day. And then if I happen upon someone who is having an overdose, I'm able to just spray it right in their nostril. And usually with 1 or 2 doses, it will help reverse the overdose and take them out of it. I think the problem, though, about having a community administered medication is that it does require the community to be able to use it when an overdose is happening. So one of the ways that we can conceptualize that readiness to use is through something that we did not call first the naloxone care cascade, but Tobin and colleagues did coin that term. We borrowed this idea of the care cascade from HIV treatment. And the idea is to conceptualize kind of what effective engagement care looks like over these multiple steps that have to happen for someone to be well treated. And so as Tobin et al. Conceived of it, they had these various steps starting with awareness, okay? And so the first step in being able to ultimately use naloxone on somebody is being aware of what naloxone is in the first place. Okay, and then the second step is being able to access it. I'll go into more detail about how we can conceptualize these in a second when I talk about how we conceptualize them. Okay, but for now, you could just take away the fact that the next step is to obviously be trained in using it. You have to carry it with you. And then finally, you have to actually use it when the time comes. So prior work has been increasingly demonstrated that access to naloxone is uneven. So starting with some smaller, more regional studies, we are seeing that there are inequities in who is getting naloxone, who's aware of naloxone, and who is actually able to use it. So this literature has been growing, but up until now, to our knowledge, no one has really applied this care cascade framework in a national setting. And so that's what our contribution is today. So we're going to talk to you today about the NMURX, which again, Dr. Burkett did a fabulous job of introing and keying up for me. But to start, if you are interested in hearing more about it, I like going back to this paper by Dr. Joshua Black, who is one of my study co-authors on this paper, along with Max Kelly from Northwestern. And it'll give you everything you need to know. But in a very short summary, we have this repeated cross-sectional study with targeting not only individuals who use drugs, but also individuals who don't use drugs. And that's important for when we think about a intervention that is supposed to be available in the general population for use when needed. So we are focusing on the study year 2024, and we ended up having a sample size of almost 58,000 individuals. Okay. And so the way we conceptualized these measures, or the way we operationalize these measures along the care cascade is slightly different than how Tobin and colleagues did it, simply because we had access to more questions. So thanks to the survey designers, including Dr. Black. The first thing that we did was ask people in the survey about their awareness. And so awareness is, do you know what naloxone is? A lot of us have heard of naloxone. Okay, so that's the first step. And if we don't enter the care cascade at that awareness step, we can't really do much about the following steps. So the next is knowing how to get it. So for me, I like to tell the story about, I started my career in West Virginia at West Virginia University, and it is known widely as the epicenter of the opioid epidemic. And so I first heard about naloxone when I was doing a community training. I happened by one that was happening literally on the street. There were chairs set up on the street, and there were people from a community outreach program who had a bunch of cases of naloxone, and they were giving us a quick tutorial on how to use it. Okay, well, I guess I can move on to the training element of this then. But the training was really almost unnecessary because we didn't get the version that was the nasal spray. We got this kind of futuristic robotic version where you just push a button and this robotic voice says, you know, align shot with person's leg. Now press button for 2 seconds, go. It's actually pretty, it's really futuristic and can help guide someone through a situation where your nerves might be running on high. Okay. And so the next element of the Tobin care cascade, we actually can divide into 2 different elements. So we have this concept of possession, which in our view differs from readiness. So possession means that you do own naloxone, okay? And that differs from readiness, which is that you carry it with you. So for me, I would carry my naloxone in my purse just because that's what I used most frequently. But when I was out walking my dog, I would take the dog walking fanny pack, which had the treats and the bags and everything in it. So I actually did not carry it with me, even though I owned it. So I wasn't ready, but I did own it. Okay, and then the final step in the care cascade is use. So this differs from what Tobin et al. Did, because we are able to actually identify in the survey people who have responded that they have been given naloxone because they overdosed. Okay, and so then to identify the racial disparities across the naloxone care cascade, which is the objective of our study, we use weighted Poisson regression models, and then we're able to calculate the APRs, the adjusted prevalence ratios at each step of the cascade. And so with those APRs, with those adjusted models, we included covariates like age and gender and SUD status, so things that we know are traditionally correlated with using illicit opioids, and also might be correlated with using naloxone and being aware of it. Okay, and then importantly, we are going to examine rates in both the general population, which, like I mentioned earlier, is important because we want members of the community to be prepared. The more people who have naloxone in their pocket ready to use it, the better. But we also drilled down on this really high-risk group of individuals who have been known to use or reported opioid use, illicit opioid use in the past year. Okay, and so that's a group that we really want to make sure is covered with this life-saving treatment. Okay, and so first we're just going to look at a very full slide of numbers, and these are our kind of summary descriptive statistics talking about the population. And I in no way am I expecting you to kind of absorb absolutely all of this. So I've put some helpful rectangles to kind of draw your attention. The first thing I want you to notice here is that in the general population in our study, we see that about 66% of individuals are white. And so that makes some sense. Okay, it makes sense that we do have a more white leaning population when taking the survey. But then in these red rectangles, which I made red to convince you of how nefarious this is, we actually see quite a shift. And so just in these kind of unadjusted descriptive statistics, you can see that among individuals who are aware of naloxone or report possessing naloxone, we see that that racial demographic mix kind of shifting toward white individuals. So we see more individuals who are white making up that group who is aware of and able and possessing naloxone. And so just looking at this, we can already tell that we suspect there might be a problem here. Okay. Now to get to some beautiful graphs that I cannot take credit for. This paper is coming out in Health Affairs in a couple of weeks. So thanks to their team for putting this together so beautifully. So you're looking at unadjusted prevalence here. Okay, and so again, I do not expect you to absorb this whole slide. So if you just kind of turn your attention to the first rectangle there, you can see that, for example, just about 35% of non-Hispanic white individuals are aware of what naloxone is. That is worryingly low, okay, if we're trying to have this be a community deployed medication. But at least we're doing better in this group compared to individuals who are of racial and ethnic minority groups. So whereas 35% of white individuals at least know what naloxone is, that number drops pretty dramatically when we turn to the non-Hispanic Black individuals who are represented by that beautiful mustard color, and then the Hispanic individuals in the red, and then finally the non-Hispanic Asian individuals in the blue. Okay? And so again, the awareness component of the care cascade is really the front door. And so it's no surprise that not only do we see these disparities kind of holding at each step of this care cascade, but we also see that just overall these numbers are so low. When you think about, if you turn kind of to the lower almost right hand side, readiness, fewer than 5% of white individuals are ready to go when it comes to actually deploying naloxone if they would happen upon somebody having an overdose. So that's a major challenge that we're confronted with. Then also the numbers are even lower among individuals who do belong to those minority groups. Now we're going to turn to the APRs, the adjusted prevalence ratios. And so these allow us to account for those factors like age and income and education. So the idea is that we can hopefully isolate some of the disparities that are attributable to race and ethnicity. And so the first thing that you want to notice here is that the associated APRs are significantly below 1, almost across the board here, compared with the reference group, which is non-Hispanic white individuals in this case. And so to kind of orient you, if you want to interpret the APR, look all the way on the left, you see that again, that beautiful mustard color dot, okay? So we can say that that is about 0.75. To interpret that, so we could say that the APR for awareness among Black individuals was 0.75, and that simply means that Black respondents were 25% less likely compared to white respondents to be aware of what naloxone is. So this pattern, just like in the previous slide, kind of remains across all of the different stages of the cascade and across minoritized groups. And then what I think is very interesting is this slide. So this slide, we're repeating what you saw a couple of slides ago. We're looking at unadjusted prevalence when it comes to these different elements of the care cascade, but we're focusing in on that high risk group. Okay, so these are adults who have reported illicit opioid use or non-medical prescription opioid use in the past year. Okay, and so even in this group, which is at the greatest risk for overdose, white adults are still demonstrating a higher engagement across nearly all the steps in the cascade. But the problem is that awareness is still below 45%. So even in this risk that is statistically so much more likely to actually overdose and die from an overdose, awareness is incredibly low, and then it just gets worse from there as we move along the cascade to the right of the slide. Okay, so we're positing that the fact that white individuals consistently report higher engagements with all the different steps of the care cascade could be one of the reasons that we're seeing this bending of the curve among white individuals and not so much among individuals from other racial groups. So I am in no way going to solve this problem today, but I do have some thoughts. The first reason that we might see this clearly is more of a structural issue than an individual behavior issue. But the first structural reason is that people aren't able to get their naloxone. Okay, and so what I mean by that is that we've had some policy wins in the past few years where naloxone has been made available over the counter in pharmacies. So anyone can just go in and purchase naloxone to carry with you. But the most high-risk individuals actually are not likely to get the naloxone in that way for a variety of reasons, which you can see on the screen and will be surprising to absolutely no one. So it's still pretty pricey. So it costs about $45 over the counter for a dose of 2 for a 2-pack. And there's, walking into a pharmacy and asking for naloxone for many people still feels very stigmatized. And a lot of people don't feel comfortable doing that. And then a lot of people just aren't aware that they can get this over the counter. Okay, so just making it available OTC is not going to solve the problem. It's going to require a more multi-pronged approach. So one of the things we can potentially do is start bringing naloxone to people rather than having them try and get it. So things like mobile delivery or needle exchange programs are a great way to get people the naloxone that they need. If stigma is an issue, we can start really leaning into the fact that this is a community medication, and we can use peer outreach movements to try and get in touch with more individuals in a less stigmatizing way. Then if the issue for what might be the case for example, the Hispanic community, we have a lot of Spanish speakers, we might need to be ensuring that we are making these training materials available in other languages in ways that are culturally competent. And then if we're not really seeing a lot of possession and training among high-risk users, maybe we lean into programs like in West Virginia. If you came into the ED with an overdose, you and everyone who was in your family or friends that were with you all received their own naloxone to carry with them on the way out. And then finally, we want to ensure that we are funding our public investment in the infrastructure that can reduce harm in this group. I suggest we start with a lot of that settlement money from the opioid settlement. Okay, with that, I will wrap up and I will turn it back over to Kate.
Thank you, Dr. Allen, for these insights into naloxone access. I found your description of the care cascade particularly helpful in interpreting your results, so thank you for that. It looks like we have a few questions. One moment. The first question is, how might AI or digital tools be leveraged to improve naloxone access and engagement in communities that are currently underserved?
I love that question. And off the top of my head, I think there are a couple different ways. One of the first things we can do, and I know some of the biostatisticians on the call might love this, we could definitely use predictive analytics to do a better job of targeting hotspots. So I don't think we can rely anymore on this concept that this is a white rural epidemic. And so really using the data to tell us where these disparities are most likely to happen is a first step. And then I think on the other side, I mentioned just a couple minutes ago using this, trying to translate these training materials into languages that can be understood by all of the individuals and outside just the English-speaking white community. And I think digital tools are definitely a way to help do that. We can use apps or mobile health apps to translate some of that training more easily into languages that can be understood and used by some of these other groups.